All right, let's dive into this interesting case. A 56-year-old woman with a 3-week history of worsening chest pain on her right side. When you hear chest pain, alarm bells start ringing, right? Especially in a patient like this with a history of breast cancer 4 years ago, treated with a right mastectomy and axillary clearance. She's otherwise fit and well, but the chest pain is enough to make us wonder, could it be something more sinister? Could this be metastasis? The imaging is where we get the answers. We start with an ultrasound of the liver, and here's where it gets interesting. A 27 by 28 millimeters lesion sitting in the left lobe of the liver, showing decreased echogenicity. Given her history, you can't help but think about the possibility of something malignant, but we need more information before jumping to conclusions. Next, we go for contrast-enhanced CT, and the lesion becomes a lot clearer. It's well-defined, 2.7 centimeters in size, located in segment 2 of the liver. What really grabs our attention is the marked vascular enhancement during the arterial phase. This hypervascularity makes us think of benign liver lesions, but we're not done yet. In the portovenous phase, the lesion becomes isodense, blending right into the liver parenchyma, and that's another clue. Benign lesions often show this pattern. Importantly, there are no other hepatic lesions, no cirrhosis, and no evidence of lymphadenopathy. Now let's move to MRI, where the real puzzle pieces start falling into place. The lesion shows intense enhancement in the arterial phase and washout in the portovenous phase. But here's what seals the deal: a central scar that appears hypointense on T1-weighted imaging. While we don't have the T2-weighted images here, if we did, that scar would most likely be hyperintense in most cases. The central scar, along with the imaging features, points us straight toward the diagnosis of focal nodular hyperplasia, FNH. FNH is fascinating. It's the second most common benign liver tumor, found in 3 to 8% of the adult population, and it's twice as common as hepatocellular carcinoma. What's really interesting is that it's not a true neoplasm. It's more of a focal hyperplastic response of hepatocytes to a congenital vascular anomaly. So it doesn't have a true capsule, but it often contains a central fibrous scar, which is what we're seeing in our patient. This scar isn't just for show. It's composed of multiple aggregates of hepatocytes, often containing fat, triglycerides, and glycogen. Kupffer cells, bile duct proliferation, and thick-walled arteries radiate out from the center toward the periphery. What's missing? Portal triads and central veins. Those are absent in FNH. Now here's where it gets tricky, differentiating FNH from other things like regenerative nodules in cirrhotic liver or hepatocellular adenoma. But in this case, the central scar and the imaging features are the keys that steer us toward it. Focal nodular hyperplasia is usually asymptomatic, and in 50 and 90% of cases it's found incidentally. You could almost think of it as a silent lesion, with only about 10 to 15% of patients experiencing vague abdominal pain. Oral contraceptives don't cause FNH, but they do have a trophic effect, which can encourage its growth. In this case, our patient's lesion is solitary, well-defined, and small at just 2.7 centimeters. Interestingly, FNH is more common in the right lobe, but here it's in the left, which isn't unheard of. And calcification? That's extremely rare in FNH, so we don't see that here either. Now let's quickly run through the differential diagnosis. The top contenders are adenoma, also hypervascular, but typically lacks the central scar that we see in FNH. Hepatocellular carcinoma. This is a key consideration, especially with the patient's cancer history. But without cirrhosis or characteristic imaging features, HCC is less likely. Hypervascular metastases, always on our radar in patients with a history of cancer. However, the solitary nature of the lesion and the benign imaging features make metastases less likely. Giant cavernous hemangioma. This is another common benign liver lesion, but its enhancement pattern is totally different, with peripheral nodular enhancement filling in centripetally, which doesn't match our case. On ultrasound, FNH can appear as a ISO, or hyperechoic homogeneous mass, and less than 20% of cases show that hyperechoic central scar. In our patient, we didn't get that finding on ultrasound, but the CT and MRI really sealed the diagnosis. Speaking of CT, the classic pattern is dense enhancement in the arterial phase, with the lesion becoming iso or hypodense in the portal venous phase and isodense on delayed images. Sometimes you get prolonged enhancement of the central stellate scar, and that delayed washout of contrast from the scar tissue can be a crucial finding. One interesting diagnostic tool is the sulfur colloid scan, which shows normal uptake in about 50 to 70% of FNH cases. That's almost pathognomonic because only FNH contains enough Kupffer cells to cause this normal or increased uptake. In terms of MRI, FNH lesions are typically iso-intense to hypo-intense on T1 weighted images, though in about 6% of cases they may be hyperintense. On T2 weighted images, they're usually slightly hyperintense to iso-intense, with the central scar being hypointense on T1 and showing variable signal intensity on T2. In about 75% of cases, the scar is hyperintense on T2 weighted images. The use of gadolinium-based contrast agents further highlights the arterial enhancement and washout in the portal venous phase, just like we saw in this case. Additionally, MRI reticuloendothelial agents, like supraparamagnetic iron oxide, can help increase the specificity for FNH, as Kupffer cells in the lesion lead to decreased signal intensity on Espio-enhanced T2 weighted images. So what's the plan for this patient? With surgery isn't usually necessary unless the lesion is symptomatic or growing. Given her history of breast cancer, we'd probably refer her to the surgical/gastroenterology team just to cover all bases. They might want to keep an eye on it with follow-up imaging, or perhaps perform a biopsy if there's any doubt. And that's the beauty of radiology, right? With the right imaging tools and pattern recognition, we can get a pretty solid diagnosis even before the biopsy needle comes into play. So what do you think? Have you seen similar FNH cases, or maybe some tricky lesions that were tough to differentiate? Share your thoughts and insights below, and don't forget to subscribe for more radiology cases like this one.